Namaste, hello, and good evening, everyone. Welcome to the third and final day of the MeHeLP Dissemination Conference 2021 Pan-India segment. Our first session for the day is about mental health policy and practice. To chair this session, I would like to welcome Dr. Nadia Svirydzenka. Dr. Nadia Svirydzenka is a lecturer in social psychology at Montfort University, Leicester, UK. She is also one of the co-investigators of our project.
Hello, everybody, and welcome to the session on mental health policy and practice. It is an important discussion about synthesizing the findings from the project and considering implications for policy and practice work. We wanted to take on the challenge of discussing future developments for the fields of mental health promotion and prevention, and how innovative, participatory, and creative methodologies can contribute to positive changes in India and beyond. Before I introduce the speakers, I would like to highlight the features of this online conference platform. So please use the lobby to engage with all the wonderful features that have been prepared to you by the conference organizers and the team, namely the films that we have created, as well as MeHeLQ. Once the conference finishes, you will be able to access these resources as well on our website on mehelp.in. So do please engage with those as well. The speakers for the session will have 15 minutes each to do their presentations, and this will leave us 10 minutes for discussion afterwards. So in order to facilitate the discussion, please use the Q&A section of your chat to pose questions to the speakers as they're talking. So we'll be able to synthesize those questions and pose them to the speakers after their presentations. So we'll have a general discussion at the end. Please also use the main chat if you wanted to discuss the topics being raised by the speakers during their conversations. But to pose questions to them directly, please use the Q&A tab. So without further ado, I'll introduce our speakers and their topics. For the first topic of how can mental health literacy shape mental health policy and practice in Kerala, we have a double team. We have Professor Raga Raghavan from Montfort University. Raga Raghavan is a professor of mental health and a PI on MeHeLP project. He's an expert in transcultural mental health and well-being, who led, integrated, and represented this project so well in the last 3 years and also throughout this conference. Raga's clinical background is in health psychology and nursing, with expertise in participatory research and co-production. So his research is encapsulated by 4 overarching but interrelated themes, which address issues of mental health, disability and well-being, specifically improving access to services and interventions, user involvement in practice and service development, and cultural diversity and inclusion. So welcome, Raga. We also have Professor Brown from Montfort University, who will be joining Raga in this presentation. Brown is a professor of health communication at Montfort University and brings substantive research expertise in health humanities and has worked on a number of AHRC-funded projects. The core of Professor Brown's work has focused on the interpretation of human experience across a variety of different disciplines, including healthcare, philosophy, education, and spirituality studies, exploring how this may be understood with a view of improving practice and with regard to theoretical developments in social sciences. Particularly, this concerns notions of governmentality and habitus from Foucauldian and Bordasian sociology, and how the analysis of everyday experiences can afford a novel theoretical developments. Welcome, Brown. So our second talk will be on mental health education and mental health literacy. It will be presented by Dr. Meena, Kolar, Sridara, Murthy. Meena is a co-investigator on the MeHeLP India project. She's working as an associate professor at National Institute of Mental Health and Neurosciences. She's specializing in major psychiatric disorders, suicide prevention, school mental health, community mental health, and documentation of IAC materials. So welcome, Meena.
Thank you.
And finally, we also have an eminent speaker, Professor Monica Lakhanpaul. Monica Lakhanpaul is a professor of child health at University College London, is a co-investigator on the MeHeLP project as well. Her research promotes citizen science using structured and participatory methods to co-design interventions and advancements of population science. She's particularly focused on disability, asthma, and nutrition as example public health issues in South Asian families. to optimize their health and later risk for non-communicable diseases.
So we'll be sending it.
She's also a community pediatrician and works directly with children and their families to understand their health challenges. So welcome, Monica. It's nice to have all the speakers on stage. And we will kick off the session then. I'm not sure if we can have the timer, please, as well. We'll kick off the session with Raghu and Brown. So please take it away.
Thank you, Nadia. Thank you for the introductions, and great pleasure to be in the midst of our crowd of our friends and colleagues who have worked together for a number of years. So let me just share the screen. Right. So myself and Professor Brown will actually go through the main findings of the project and how it might actually shape the policy and practice in the Indian context. So without further ado, we will kick off because we think we need to look at the time factor and try and finish on time today. So so at the very first day, I talked about what is mental health literacy. And I think going back to the same question about what is mental health literacy, we have we had the 6 dimensions that has been proposed by Jerome and in about two decades ago, in terms of the ability to recognize specific disorders and different types of psychological distress. And also we have the knowledge about risk factors, and knowledge about self-help interventions, and knowledge about professional help available, and attitudes which facilitate recognition, and the knowledge of how to seek mental health information. Obviously, this is based on the Western medical model of that everybody should be going to see a psychiatrist or a psychologist if they actually have a mental health issue. And I think that's what this is actually primarily based on. So our own work has to actually shift slightly from this, including all those things from the generic mode, but also would actually include the how does culture and cultural awareness and how does cultural heritage actually influence all these notions about awareness and understanding and help seeking and other issues. So just to go through some of the key findings from our project that might be applicable from the pan-India perspective. So some of the key findings are the knowledge of risk factors and causes are actually influenced by a socio-cultural milieu of things, and how the issues surrounding an individual, their family, and the neighborhood, and the whole idea of living standards and access to work and any other issues might be relevant to them are actually very important here. And in the Kerala context, I think people living in rural and tribal Kerala kind of associated the causation of mental health problems primarily to God's destiny and supernatural causations as well. I think that might be also be applicable to many other Indian states in the urban and rural areas too. So the urban areas actually associate causation to both of them by a medical model because maybe the understanding or their experience or they have actually been in contact with some of the mental health services. And tension was mentioned as a narrative across the science as a cause of mental illness. So tension is a key word that people have actually come out in all our narratives. Whereas in the West, we might actually say that I feel sad, I feel depressed. Whereas here, tension seems to be a key word that people are actually using to kind of try and actually express any mode of their kind of emotions or feelings. So depression is distinction between intense sadness as an illness and everyday sadness as part of the as life passes, while others do consider it as a mental health condition. And Vishadam or depression actually prevents a person from doing his or her routine activities. And I think they actually brood and don't do any household chores or work. So some of the husband and wife kind of argument happens. And madness, the kind of the national Hindi word of pagal, or in the Malayalam context, or vatu or brantu, where a person behaves violently and throws things around and physically abuses people, and loss of mind is also a notion that people have actually expressed. And then there is also the compulsive behavior in the northern Malabar community in Kerala. There was a mention about aswas and compulsive behavior, often linked to the possession context too. And some of the services and caregivers in the urban area were able to use appropriate medical terminology to describe their illness. So I think they might have been used because I think they have been in contact with some of the services that are actually in their neighborhood, or have other people who obviously inform them of those services. And some of the economic burden is a key factor here. Economic burden as an overarching theme that we found in the rural and urban areas. And it actually influences the utilization of healthcare, because it's the amount of money that people might actually have, whether they want to go and see a local psychiatrist or a psychologist. First of all, there is the awareness of the context, and also whether they're actually able to afford any the fees of the local psychiatrist or the psychiatrist, psychologist, if they're actually going to see a private sector or any of the hospitals. That is a critical factor, and hence people might actually go to a traditional healer or other kind of therapists actually around who are much more affordable for those communities. So in the urban sites, work pressure and restrictive societal norms were actually described as one of the key issues for for them to actually access any of those services. So from next, Brown, Brown for this context.
Yes, thank you very much, Professor Raghu, and thank you very much indeed to Dr. Svirydzenka for that most generous introduction a few moments ago. Now, one of the things that came out strongly from the large body of interview material which we accumulated in our project was that there was a degree of what we've called psychiatric pluralism, and many people, perhaps particularly in urban areas, were familiar with more global north medical understandings of mental ill health and distress and disorientation. But equally, and perhaps particularly in rural areas or tribal areas, people were well aware of the spiritual and traditional healing traditions too. And it's as if people were literate in a number of these different healing regimes and a number of these different traditions. So that's one of the reasons why we increasingly are talking about mental health literacies, plural. And people's choice of who they approached, choice of help seeking was based on awareness, accessibility, and availability of resources. That there may be traditional healers in one's local community, in one's village or one's street, going to a mental health hospital might involve going out of area, having to go and talk to loads of people you don't know, and might be stressful in its own right. That generally speaking, rural participants were more inclined to endorse the traditional methods. However, even in rural areas, people did see, on the whole, a role for psychiatric medications as well as religious observance to help recovery. On the other hand, urban respondents were more inclined to say that they would modify their lifestyle, perhaps to reduce tension, as well as visiting a psychologist or a psychiatrist. Raghu, can we have the next slide, please? Now, as we've implied, in rural areas, the faith healers, religious healers, traditional healers were often seen as the first line of management if someone was distressed or disorientated or others felt that they were behaving oddly. Ayurvedic medicine was also a popular resource, and also with some of these traditional and spiritual approaches, they were specific to particular religions, cultures, or regions. In rural areas, people consulted a variety of people, Hindu priests, they deployed a so-called black magic, they consulted Mantravadis, and there were rituals like Haman and Kalam, which involved sacrifice, and these rituals were believed to free the person of the evil spirits which were believed to be causing the problem, as well as participation in more, shall we say, mainstream or conventional religion, going to church, going to the temple, going to the mosque, prayer, meditation, and ritual were important resources which people used to attempt to relieve the symptoms of mental ill health. There was some ambivalence, though, about these religious healing practices. Some caregivers extolled the benefits of these healing practices, while some people felt it could even make people worse. In Chatanikara, there's a famous temple there where people from all over the state of Kerala, indeed from all over India, go to cure mental health problems. And in Chatanikara, temple visits were seen as perhaps not necessarily curing things, but perhaps imparting well-being, giving people a sense of inner peace, rather than curing people's problems outright. In Islamic areas, like in Malappuram, Islamic faith healers were widely consulted, and there were a variety of rituals and activities they could do to exorcise the evil spirit or the jinn, which they believed was causing the problems. Can we have another slide, please? Now, as you might imagine, families were very important as sources of support, but they also emerged as a source of stigma as well. Family members somehow didn't understand. Family members sometimes responded negatively or even aggressively to people's mental distress or confusion or disorientation. There was also a strong sense in all areas that people needed to hide these problems, that it was something that you shouldn't talk about. It was something that would impede your life chances for marriage, for having a family, in the world of work or the world of education. And whatever religion people participated in or subscribed to, prayer was an important self-help strategy, which was seen to improve well-being, happiness, provide a sense of peace, and as an aid in recovery. Ooh, let's have another slide, please. So, mental health literacy then. Now, Professor Raghu has outlined the core components of mental health literacy as it was originally conceived by Jorm and his colleagues back in the late 1990s. Whereas what we've discovered is that people seem to be literate in a whole variety of different healing regimes. Now, to make inroads in policy and practice, I think there needs to be some sort of dialogue between the medical, the psychotherapeutic, and the spiritual and traditional approaches. Now, the reason we outline all of this is because in order for policy initiatives and healthcare initiatives to work effectively and to be acceptable to the population, they've got to take cognizance of the local context. As many of you are probably aware, there's been a great deal of skepticism from post-colonial scholars and activists and practitioners themselves about healthcare problems which have been initiated and conceived in the global north, which have then been exported to low to middle income countries. You know, things like, in the case of mental health, the World Health Organization's MHGAP programs and so on. So if there was more dialogue, if there was more rapprochement between traditional and psychotherapeutic and medical regimes of healing, perhaps this would be an important step in the way forward for mental health in a country like India. In the rush to modernize mental health services, policymakers and health leaders, please don't forget the important coping resources which already exist within the country, within communities, within families. And rather than trying to sweep all this stuff away and call it, oh, it's just old-fashioned superstition and stigma, maybe it's a whole lot more than that. These are forms of belief and forms of practice which have existed for generations and from which people derive a great deal of comfort and succour. Let's have another slide. So, as I've just hinted, mental health literacy campaigns often assume that the medico-psychotherapeutic model is the best one and that everything else is just superstition and stigma. However, it's important to recognize how the traditional and spiritual activities give meaning and structure to people's lives. They bring them into contact with others in the form of the social relationships that exist within religious communities and congregations. They provide structure to the day. These are the rituals we do in the morning. This is when we visit the sacred mangrove. These are the rituals we do in the evening, and so on. Whereas taking tablets, for example, may control the symptoms, but it doesn't necessarily give you your life back. And also, don't forget, if people aren't talking about things, aren't talking about their distress, it may not just indicate stigma. After all, even in the most collective and communitarian societies, people often find it important to maintain a degree of privacy. You know, there are certain aspects of one's own affairs that you don't want other people knowing about, and that's an important part of being an adult and being, you know, a full human being. So let's not be too dismissive of the practices and beliefs we find in urban, rural, and tribal areas within India. Okay, that's me done. Let's have another slide. And perhaps at this point, we'll hand back over to Raghu for some comments on policy directions.
Okay, thank you, Brown. So I think in that context, from the pan-India perspective, we should be looking more about the public health, public mental health programs and how mental health literacy and mental health awareness are actually absorbed into the existing structures of primary care, district mental health programs, or the NGO programs, or any of the other programs that actually exist from district level and state levels as well. So that is one of the key things that we should be looking at. I think it's been also been echoed from other conversations over the last 2 days from learned people of NGOs and other policymakers over the last 2 days in the conference. And integrating public mental health programs to the grassroots organizations, the primary care, some of the ASHA workers program, in the Kerala context, the Kudumbashree program, and the NGOs is actually vital in relation to spreading that message so that more people are actually aware of it. And the thing is that, you know, whether knowledge actually creates that attitudinal shift in people to actually understand some of those things is something that yet to be studied. But I think we do know from the available evidence so far that the awareness and knowledge actually does create some behavioral changes. And mental health literacy and well-being and resilience programs, I think, should be in schools and colleges and universities so that they have the right knowledge and the right kind of information to actually make decisions for help seeking, and also to try and look at some of those self-help models that they might be able to actually try and practice by themselves in terms of mental health and well-being. Because mental health is a different concept than the mental illness concept. So I think it's important to try and see what is mental health from the wider context here. And mental health literacy it should be also part of all professional programs that are being delivered throughout India, and also any not just in the professional program related to health or medicine, but engineering and IT and other courses as well should actually have mental health literacy as a key element in that. What we must also try and do is also non-medical. We should try and not medicalize mental health and well-being, and I think thinking that everything is actually a distress mode and everything is actually got a medicine that we need to actually take to cure that. But available evidence worldwide does not actually prove that equation at all, regardless of, because I think it's important that we try not to medicalize our own emotions. And it should be delivered to the cultural organizations, and digital media plays a major role in terms of how the mental health literacy can be ingrained and that promotion activity can be taking place, as it was actually described by Anisha Padkone yesterday. And I think The diversity of approaches is very important because there is no one size fits all approach as to how we should actually spread mental health literacy. And I think that is for the diversity of approaches, the diversity of methodologies, the diversity of conversations, and all those things actually add to the creation of that knowledge and change into a better, culturally appropriate mental health aware society and a country. I think just a last point in terms of note, I think, is because I think the media portrays mental health and well-being and mental illness in a different mode. And I think it is time that we as a society should be looking at how the media portrays it. And perhaps there should be mandatory training for the print, visual, and digital media workforce. Thank you very much.
Thank you very much, Professor Brown and Professor Raghavan, for your contributions. So next we will move on to Dr. Meena, who will talk to us about mental health education and mental health literacy. So the stage is yours, Meena. While this is loading, I just want to note Q&A for all the participants. Please do post your questions there.
I think everyone can hear me now.
Yes.
Yeah. Thank you. I'm Dr. Meena here, Additional Professor and HOD of Department of Mental Health Education, NIMHANS, Bangalore, and I'm very proud and happy to be part of this very thought-breaking and innovative MeHeLP conference, and also part of the research team. And today my topic for the presentation is on mental health education and mental health literacy. I think my initial few slides could be, a repeat of what Dr. Raghu and Dr. Brown have shared, but I'll just quickly go on to, and when I would like to, when I reach the slide of mental health education, I would like to give a lot of my personal anecdotes as being one of the main departments, maybe just the one or two departments in the world which has a exclusive department of mental health education here. So I think I'll just, the conference has spoken a lot about mental health literacy, the importance of it, and how it's a very important aspect in the journey of mental health. And I'll just quickly recap those. And it's a concept, the importance of which has grown lately in the domain of health literacy. And we see a lot of research being conducted around the around mental health literacy. And mainly it refers to the knowledge and beliefs about mental health disorders, which aid in the recognition, management, or prevention. And we see a lot of research happening within NIMHANS in India also in this particular context, whether it's in the rural or in the urban, in the colleges, in the communities, schools, and companies also. And mainly we can see that it can be explained as awareness and knowledge about mental health and its related problems that help in early recognition, management, as well as prevention of the same, to lead an overall healthy life. And in other words, we can tell that it's a very foundation of the promotion of positive mental health, so that best available care can be provided to a person in need. And despite its importance, we are seeing that mental health literacy seems to be quite a neglected area of health literacy, especially in a developing country like India. And when we look at the National Mental Health Survey being conducted by NIMHANS in the year 2015-16 by the Department of Epidemiology and Center for Public Health, we found that the Indian community was seeing an increase in the rates of mental disorders, and the treatment gap from the person visiting the hospital when he or she is diagnosed was very delayed and it was very high. And statistically speaking, we saw that around 11% of people in India above 18 years suffer from mental health disorders and they're not even receiving basic treatment or medication also. And many of them were not even aware that they were actually suffering from some kind of a mental health problem. And one of the reasons we saw for such poor treatment seeking is because of the limited knowledge. I think that was one thing which came out very strongly in the National Mental Health Survey, that limited knowledge and poor education was one of the reasons that people were not recovering well enough or were not seeking treatment. And these were some of the initial, we saw some of these studies which have been done with regarding to mental health literacy, and we see that some of the significant findings that we see in these findings are that need to understand the local and cultural context of stigma to develop very effective and innovative methods, and we need to bring an attitudinal shift. And some of the things what Raghu and Brown have actually spoken has come up across in many of these findings in the Indian or in the international studies. And a lot of emphasis was on the mental health first aid training, which needs to be very rigorously planned around the communities for improving the health literacy. And if you look at the role of mental health education and going forward, we see that health education is very crucial to public health. And we see, and even when we talk about India, and when I have actually gone back and seen that have there been any specific, some kind of modules that are there for mental health education, we didn't have anything, and it was just focused on general health education. And then we had to actually, when I came to the Department of Mental Health Education, then we had to actually look into what are we trying to do, how as a department are we going to make some impact to the community. And public mental health requires a robust foundation of mental health education to maximize the impact on the community. And mental health can be effectively enhanced by mental health education interventions. And mental health education and it can be targeted to various audiences, whether it's teachers, and it can be tailor-made to adolescents and professionals through various mediums, online or offline, through promotive, preventive, or educative approaches. And it's also imperative to evolve mental health educators who would be individuals in the community who may or may not be mental health professionals and who could be more practically effective in engaging in their community. And I think this was one thing where, and when we look at our objectives from the department perspective, the first objective is what Raghu has already emphasized in the last presentation was, that they need to be a mandatory training in developing audiovisual aids or, videos or, some kind of specific methodologies to impart mental health education. And that's what the department has been doing. And we see that every time we are actually calling out for people, for internship in mental health education, we do have a lot of people who go back with a lot of positive feedback that this is this is not what we are learning in a mental health curriculum. And and they're surprised that that there is some kind of a department like this which actually teaches how can we go about in developing content, pre-testing it, post-testing it, and we can look at it from a scientific perspectives also. So and I think some of the things that one you need not be a mental health educator also as we are talking, and we have actually trained people, more than 5,000 people from the community who can be actually called as first aiders or people who can actually identify people in the communities who would be having a mental health crisis. We are not even looking at do you want to identify someone with a mental health disorders? No. Every person has some day-to-day crisis, and how this person from the community can actually identify a person who is undergoing a crisis. It could be something that I have lost. I was supposed to go to UK tomorrow and I lost my passport. I lost, I'm not finding my passport and has a mental health crisis. Or it could be someone who is just body shamed, or it could be someone who was who was touched inappropriately when he or she was traveling, and you have a mental health crisis. So how could you reach out to these people, and how could you actually reach out and try to actually address their mental health concerns? So I think we would have been training nearly 10,000 and more people from the communities on a periodic basis, and these are the people, we tell that they need not be mental health professionals, but they could also in some way make a positive impact in the community by addressing the crisis, and they could and we could actually do some kind of a capacity building by actually training them, equipping them with certain skills that are needed for them to reach out and help a person who is undergoing this kind of a crisis. And developing a group of mental health educators, like I told, we have actually worked with college students, with homemakers, with industrial workers. We have actually trained many people from various central government and state government organizations. And we see that we are also looking into from the training of trainers perspective, where these people are actually, it looks like something like a snowball effect or a ripple effect, that they actually go and they train a larger community of people, and they are actually talking about mental health problem. And we also make them equip that start talking about mental health. It could be a blog, or it could be a campaign on social media that you would like to do, or it could be something that you want to start writing in the newspaper, networking with the media also. And all these actually can lead to an enhanced help seeking behavior amongst the members of the community. We had a person who was actually who was driving an auto, and he saw this ad where he had just parked his vehicle in front of our department, and he saw that this is for anyone from the public. And then he just walked in and he told, can I be a part of this training workshop? And he was so happy, and he told, this is something like an eye opener. I didn't know that many of the things that you were talking in the program could actually be, I could reach out and help so many of people. And these are the kind of problems that people have actually come and spoken to me, but I didn't know how to go about this. And I thought it was not at all a problem, or it could be something just that, they could sort it on its own, or it could be just like something like a passing cloud, which is there now and it just goes away. And these are the educators who can actually significantly contribute to the betterment of the community by being vocal advocates of right to autonomy, right to seek information about treatment, exclusions brought about by stigma associated with mental disorders, the need for importance of promotion and prevention. And we still see in India and in the schools, especially even in Bangalore, that when I have reached out for talking about suicide prevention in various schools for one of my research projects, I was actually turned down from many schools, telling that we don't want you to initiate this conversation of suicide prevention. And by doing so, we are actually, maybe the children are not thinking, but the thought of that can actually make them commit suicide. They're not even aware of suicide prevention, so please don't initiate such kind of conversations. And I had very difficulty actually when I had to actually get the samples for my study. So we actually struggled for 1.5 years, and we had to change our sample age. They didn't want somebody from 10 to 12 years or 15 to 17 years that we talk about suicide prevention. So that needs, I think, those kind of we are seeing that there's a lot of stigma associated with talking about certain illness also. It is not about associate, then forget about what if the person actually commits suicide or attempts to suicide. When the word itself, there's so much of rigidity when talking about certain things like suicide prevention or depression or I'm feeling low or anything like that. And we need to like earlier Dr. Brown was saying that we need to look at very holistic path in increasing the health literacy. And I feel the mental health educators need to be grounded so much in reality, and we need to take a very holistic path in increasing the health literacy of the target population. And both the health practitioners and mental health educators need to work hand in hand to spin this biopsychosocial, socioeconomic wheel to address the wide arrays of determinants of health. And when mental health related interventions are planned and implemented in the community, we can, as mental health educators, can be key stakeholders and be involved in the monitoring, evaluation, and communication of the crucial outcomes. And the feedback loop, I think, will definitely help us to separate out the ineffective strategies and thereby preventing wastage of valuable resources. Because we see that and like all of us have been telling from past few days that, India is a very diverse country. And we see that itself, like what works in Bangalore might not work 100 kilometers or 50 kilometers. You go just outskirts of Bangalore, the same intervention that we plan for Bangalore city might not work for something, when we go to downtown Bangalore, and, it might not actually, so we are always, we need to be curating specific content, looking at it from the cultural perspective and what the person or, what the particular community needs. So as mental health educators, one need to be constantly, thinking that, what will work best for this community. And recently, when we had a program where we had to actually train children or, educate children about the brain, so then I had to actually reach out to a theater group, and work with them, and we had to use some kind of a technique, called as bunraku, which is a Japanese way of puppetry. And so we had to use the bunraku technique to actually educate the children about brain and its functions. And we thought, and this was the best way, and the children really enjoyed it, and there was a lot of laughter. And then, when we did a post assessment, we saw that the children were actually like looking forward for more sessions on this, and they felt that, and it was in a very fun way, and they could just actually connect to the characters. And also, and then we had to literally, we have to actually, then they were feeling that, okay, this is the first thing you're showing. Can you show us similarly on various how stress can affect our body, or how our emotions being controlled by the brain, or all these things. So it was like, we were encouraged to actually use this particular technique for further educational purposes. And mental health educators, I think, need to develop the skills to convene and manage health related debates, and develop the sense of accountability among a variety of stakeholders. And we need to collaborate and develop new partnerships that can together complement each other in working towards the mental health professional of the community. And as educators, we need to actually always keep looking out that what works best. Actually, like for example, now we had actually the department recently completed its 3-month certificate course with media and mental health. And we saw that there's so much of content that actually came out in working in collaboration with multiple media students and journalists who are already working in various media houses. And we saw that how they are such a strong group in actually building up a campaign, or writing a very strong story, or debating on certain aspects of mental health. And we saw that this is one very strong group that can actually we need to really strengthen, and we need to actually go hand in hand actually in making some impact with related to mental health.
Thank you, Meena. Sorry, I just need to cut you off there. We're very much over time now, and I would like to have some time for the next speaker. So thank you very much for your presentation. I'm sure people can get in touch with you to discuss this further. So if we can continue to the next speaker, who's Monica Lakhanpaul, who will speak about the role of creative arts and influencing policy from a global perspective. So please, Monica, if we can have your slide and your talk. Thank you.
Thank you very much. Can you see my slides?
Yes, absolutely.
Perfect. So thank you everyone for inviting me to present today. It's a great honor, and I will try and speedily go through these so that we have a bit of time for questions if we can. I'm coming at this from quite a different direction really, and really just to give you a very an overview really of how we can engage more effectively with policymakers. And as we know, engaging with policymakers is so important, because without that, we can't have impact on what we're trying to do. And so it's something we have to build into all our work. And policymakers literally have a few minutes to read massive documents, words and words and words and words, and then they have to very quickly take out something from it and act on it, or decide if they're going to act on it. So we have a job to do, and to try and ensure that we embed within their thoughts and emotions something very important. So that's what I'm just going to try and give you some suggestions on how we can we can do that. So we've talked a lot this week and last week about different arts, audiovisual, visual arts, performing arts, literature. So there's many, many different art forms that we can embrace to use as a tool for engagement. Now, this isn't something new, and I'm not going to tell you anything that you don't know. It's more to really just bring it back into your thinking. For years and years and years, long time, we know that propaganda, art has been used as propaganda. We've used visual images, we've used statues, we've used slogans, and that's been the norm to try and get messages across to policymakers. So some of you may or may not know of the street artist Banksy, but he was very well known for placing on walls, really, and murals, using murals as a way of having a dialogue with policymakers, particularly in the Israeli-Palestinian conflict, when he was trying to get over some very, very critical messages to people. And he was somebody who is named a number of times about the street art that he has done. But closer to home, and some people think about this and some people don't, but I've become quite interested in Indian truck art. And the fact is that that means the community decide on the messages they want to put onto their trucks. They own those messages themselves, and they paint them onto their trucks. And these trucks go around the country. So they're great vehicles of communication. And again, if you're trying to get a message out to policymakers, you have to hit them at multiple times. You have to make them think about what you're trying to say. So having truck artists as a way of delivering messages to policymakers, for me, is actually a very creative way of getting the community messages to a wider audience. So what's the role for art in policymaking, and what's the thoughts from some experts? So I'm just extracting these thoughts from some experts that I've heard about. So this is a professor of politics at the University of Stirling, and he suggests that successful advocates on policy issues recognize the value of emotional appeals and simple stories to draw attention to a problem. There's always been a conflict between people who think we should be using emotion to influence policymakers, or we should be using evidence to influence policymakers. And in my feeling, it's not one or the other. We use evidence and we use art as a way of a communication tool. And the artist below, Olafur Eliasson, says facts are one part. Just as guilt does not inspire initiative, people will not act on facts alone, which is what I was trying to say. We are inspired to act by emotional and physical experience. And that is just human behavior. You read something, yeah, you read it, you put it down. You see something, you feel something, you're more likely to act on it. So you just have a look at this picture there. If I wrote you a long report, which showed you that picture, it may not hit you so hard. But as we can see here, the picture, the photography itself shows the reality of people's feelings, their emotions, their community needs. And if activists have used this in their campaigns as a way of pulling the heartstrings of society, and yes, some people will criticize that, and some people will say it's not a good way of presenting individuals, and does it stigmatize individuals? Is it unfair? But sometimes it's being used for a reason, because without that, sometimes we can't bring about change. So as you can see here, it says at the bottom, when an artist creates great music and movies, it entertains people around the world. So this is making a difference by using art, but impacting on society. So Stephen Bennett, in his blog as well, has also said three things. You know, we can use art for a way of engaging policymakers with data and evidence. So it's still evidence driven. Thinking about the future, creating approaches to policy making. So that means engaging policymakers in a dialogue, and also using it as a way of raising awareness to them about some public issues that we want to take forward with them. Now, this is a piece of work that I'm doing at the moment with my colleagues, and it's a piece of work we've been doing with policymakers in Brazil, but now we're doing another piece of work in Africa, South Africa, with policymakers using a similar methodology. And what we wanted to show was that sanitation by itself has so many linkages to mental health, to well-being, to poverty, to social justice. I mean, it just links to everything in the Sustainable Development Goals. But just writing that, and we did produce a very big report for them showing that and all the linkages. Actually, you know, can you read all of that? And are you going to do it? You'll lose them in 2 minutes. So we translated that into an image here. And when you put this on a big board, it's much easier to see. So to me, this is art. This is art. We're using infographics, we're using art as a way of translating evidence into a dialogue that actually policymakers can just visually look at in a quick and easy way and grasp. Another a bit of an example of this is an exhibition that was done in East London. And what they did was they used bottles as a way of showing life expectancy. And they were trying to show people the difference in life expectancy in one part of in London and the other part of London. So blue bottles meant one thing, amber bottles meant another thing. And viewers reported that experiencing the data in this three-dimensional setting actually made them aware of a trend they'd not previously appreciated, because they could visually see the difference between the life expectancy that, again, in words doesn't always come across. And thinking about the future, how can it be used to actually take us into the future as well? So this is a picture on the right-hand side, and it's something called the Museum of the Home. And again, how will our homes look like in the future? So we're going to be embarking on a project called Tomorrow's Home, where we'll have engineers, we'll have policymakers looking at what tomorrow's home would look like with technology. But within that, we will be also showing what it's like to be homeless, what it's like to be in insecure accommodation, to enable policymakers to say, yes, you are going to put so much money behind X, Y, Z in making all of these technology solutions for wonderful, rich homes. But actually look at the way some of our people in poverty are living and visualize that, and what are you going to do about them as well? So that this, again, is a way of translating a lot of research we're doing on poverty and inequality into a immersive exhibition that policymakers can actually feel and touch and smell. This is taken from an exhibition you probably all know about in Dharavri in Mumbai. And this is where the local community wanted to raise awareness about the lives they were living. And it's a very clever way of doing it. So they use these tin cans to create an image. And on the images, they put photographs as well. And so you're doing two things there. You're drawing in people to the fact of, their lifestyles. You're making a piece of art that people can actually see, and it's quite large. And then on each individual tin, you put a different picture that actually moves you and takes you and draws you into people's lives. And again, here's a project that we've done in India, actually, just during the COVID period. We were very, very concerned that children were being locked down, they weren't eating properly, their lives were being affected, their mental health well-being was being affected because they couldn't play with other children. They couldn't get to school. Some of them were being abused, some of them were seeing domestic violence, and some of them were living quite difficult experiences. So rather than ignoring that, we actually did take COVID safe approaches, and we engaged with some of the children in rural areas and in some slum communities. And we thought, what better way to draw policymakers attention to some of this, because people aren't really listening to us. And so we tried to create an art exhibition where we got the children to draw what their experiences were. And you can see on the left-hand side, we can see that they're talking about schools and the lack of school. On the right-hand side, it's talking about fruit and play and the lack of being able to play. And we have many, many more of these pictures as well that we can share with you. So what did we do with that information? Well, we created this exhibition, and this exhibition was called the Early Years Exhibition. So as we know, something that's very close to my heart is the early years and the importance of mental health and well-being and physical health, preconception right the way through, and starting early to actually give children a better start in life. So through this exhibition, we were able to make a virtual exhibition, so you can all see it, and I can send you the link to it. And it presents photographs from some field work we've done, drawings, the ones that you've seen, and many, many more, to really take people through an experience through this art exhibition. But we didn't leave it there. We linked that to a webinar with actually one of the principal scientific advisors to the government of India, who you all will know, Professor Raghavan, and many other people as well who were on the panel, so that we could have a debate around early childhood. So it was used as a tool, as a way of promoting conversation. And I think that's what I'm trying to say, is that art in itself is absolutely beautiful, but it is so important to utilize it to actually enable us to have a dialogue with audiences who otherwise we can't engage with because they just don't have the time when they're going from one activity onto another activity. And I really want to leave you with some, if we can, some time to have some questions. We have hardly any time left, but so I want to just end on this last few words. And these are some quotes. I considered any art pointless if it did not put itself as a disposal of political struggle. My art was to be a gun and a sword. The function of the artist in a disturbed society is to give awareness of the universe, to ask the right questions and to elevate the mind. And I'll leave you to read the last quote so that we can move on to some questions. But thank you for listening, and it's been wonderful to be here with you. Thank you very much.
Thank you very much, Monica. And yes, we do have a few minutes for questions. There was interesting discussion in the Q&A, particularly around the dialogue that all of the speakers have commented on from their perspectives in terms of how do we sustain or create this dialogue around mental health. And there's been some answers from Raga as well in the comments, so thank you for that, for engaging with it. So I wanted to, and there's a question for Meena as well around speaking to adolescents particularly. So maybe we can, in the last few minutes, have a comment from the speakers to synthesize, I guess, a take-home message from their perspective around how do we have this dialogue around mental health with a particular population or particular methodology, to highlight community experiences to policymakers, to highlight these conversations, to have about health, not necessarily illness, not stigmatized, but to be inclusive in that. So if we go in order of presentation, so Raga, if I give the word to you first.
Yeah. Quickly, I think we need, looking forward, I think we should be using the medium of digital technology to actually tell stories, good stories of mental health and well-being, and also to try and influence through those kind of mediums and to the policymakers and government officials, etc. Really, and some other points that Monica well made in terms of the lorries and the buses and other stuff are actually very, very important ways of actually communicating that information. So I think creatively and think outside the box, and how is it that we can promote it.
Thank you. Brown, any thoughts?
Yeah,
sorry, you're on mute.
Okay, I've just unmuted myself. Thank you. There's some interesting points raised in the Q&A, and I suppose one of which that resonated with me is something Meena mentioned, that if you're, for example, trying to discuss suicide prevention with young people, there are gatekeepers like school teachers or parents even, who might say, no, we don't want you talking about that because it might encourage them. Now, this is one of the advantages that some of the creative and performative traditions that we've been talking about have. They can kind of fly under the radar and build awareness and generate conversations in a way which doesn't seem so contentious. It also provides a way of engaging with policymakers, because as well as very evocative images, you know, an image of a starving child is worth many millions of words written about child poverty and malnutrition in low-income countries. But it also gives politicians and policymakers something that they can have their picture taken, shaking hands in front of. You know, rather than say a cardiac unit where we're going to do heart transplants, or you know, a hospital where we're going to cure cancer. You know, if you've got an exhibition, if you've got a show, that's something they can engage with as well.
Thank you, Brown. And Meena, I don't know if you wanted to comment specifically about working with adolescents and children, and some of the things that you can do from your own experience.
Yeah, from the department experiences, what we have seen is we have used actually, like, one was the Bunraku way method of actually educating the children about brain and its functions. And the others, what we have done is we have also looked at from the street play, and, you know, and more when it comes to children, we have used art as one methodology to actually educate the children about mental health. And recently, what we had also done was we had actually we were inviting children to actually come over to NIMHANS in collaboration with the NIMHANS Heritage Museum. So actually, you know, look at how mental health settings are, and that is one way of educating children. And while talking to few researchers or few mental health professionals, and when they looked around the campus, that it was not but it was a very different kind of a strategy we used, where they just meet professionals and they talk to them, and some of the ideas about mental health is addressed, and the stigma that they have, that this is not the way a mental health institute, or this is not the way their idea of about how a mental health professional looks also is very different from the media perspective, how media has portrayed mental health professionals also. So that was one way of actually bringing them and interacting them. So this is something which we have been doing with the public, and inviting them to NIMHANS, seeing how the wards are, seeing how the institute is, talking to mental health professionals, looking at the current research that has been happening, whether it is brain stimulation, or whether it is MRIs, or is it yoga, or is it mix of integrative medicine, all these things. And when they come, they're like literally, and the beautiful gardens, how the surroundings are, they're not chained. And also these are some of the different, we need to constantly keep, like I told, it is a challenge for us that every time you're constantly trying, how can I creatively get the message across, how can I make it interesting, how can people start talking about mental health. So this is something, as the mental health education, we take it up as a challenge every time, how different can we do from the rest.
Thank you. So demystifying the process of it. And Monica, any final thoughts?
Yeah,
thank you for your presentation. Yeah.
Thank you. I'll keep it quick. So one thing I'll say is talk. The more we talk about it, the more it normalizes it. The second thing I'll say is mental health isn't for somebody else. We all have mental health, and we all need to be talking about it as part of our, in a holistic way, as part of our being and who we are. And I think we need to try and move away from this is a mental health problem, which is medical problem. Actually, it's about like I say in the Q&A, it's about thinking about preconception, and having mental health is actually part of your journey through life, from the moment you're conceived and before you're conceived, right the way through. And the third last point is stories are great. Having advocates, having elders who want to talk about the stories of their journeys through life, because then they can give permission to the younger people to feel it's okay to talk about it.
Thank you very much. Thank you very much for your speakers. I do apologize, we ran a few minutes over, but I think those were really, really important summative comments at the end. So thank you very much, and for everybody who participated and asked questions. And we move on to the wonderful workshops in the rooms now. So thank you very much.